that this effect may be somewhat specific to youth, and that it also may be more pronounced in young women. And so, and this is kind of like the initial broad correlation that has driven a lot of the speculation about social media and its causal role in mental health problems. Because there's a sort of a temporal matching between the onset of people using social media and the increase in that and some of these secular changes in these rates of mental illness. Now, I was going to spend some time talking about where the evidence is on this, but in preparation for this, I had a look online and I saw that you've had Candice. I'd just come and speak to you, and of course, Candice is a genuine expert on this topic, and so hopefully you saw her talk, and if you didn't, go and watch it, it's excellent. And Candice summarised the, so I'm not going to dive into it deeply, except to say that I think my summary, I think, would be quite similar to Candice's, which is that the evidence for causality between these two things is quite weak and possibly even non-existent. Now, causality in science is a super hard thing to prove. And so we've got to be aware of that. But we do see some evidence of relationships, but it tends to be correlational, cross-sectional, and it tends to be related to ways of measuring how people use their devices that are going to logically correlate with other things that people are reporting, like whether they're feeling depressed or anxious. For example, today I just saw a report that came out, a new journal article saying that drinking milk tea or feeling addicted to drinking milk tea in China was associated with depression, anxiety and suicide. Now, I'm sure that that correlation is real because what we're talking about there is reporting I feel addicted is correlated with reporting I feel depressed and anxious. And that's very different from having a causal relationship. And as Candice summarised in her talk, there's actually even some evidence that the causality might be the other way, that young people who are feeling more distressed turn to online experience as a way to respond to that, whether it's information seeking, social support, etc. So I think I do think, but one of the things that's really compelling about this narrative is just how powerful it is. I've given talks to all sorts of community groups on this topic, and I cannot tell you, even when I'm talking to professionals, you know, I remember speaking to a group of paediatricians and they were like, you must be wrong. We know this to be true, right? And so there's a very powerful narrative about that. And I think what's important from a rights point of view here is that we need to be aware that youth have both protective and participatory rights. So they have the right, of course, to be protected against harmful things. And there are certain kinds of experiences that we do protect young people from because we understand them to be potentially harmful in a way that they wouldn't later on in life, or that we consider the person to be fully mature, whatever that may mean, and have agency to make those decisions, like whether they smoke cigarettes, drink alcohol, look at pornography, things like this. So we have rules about that, and they're designed to be protective. But this is where digital technology is has another important aspect to it, which is that youth also have the right to participate in these very profound technological changes that are occurring in the world in which they live. And they have a right to learn about them and interact with them, because can you imagine someone who arrived at the age of 18 and was given their first exposure to internet-connected devices at that age, just when they're going to university, going out into the workforce and so forth like that? You could argue that they would be ill-prepared. Not to mention the fact that things like healthcare and other things that are increasingly mediated by these kinds of devices. So whenever we talk about regulation, legislation and education in this area, we need to find a balance between these two important kinds of rights for young people. So the issue that I'm really focused on is in mental health. And I do want to talk for a minute about what the big problem is here. And the big problem is really the problem of supply and demand. We have an enormous need in the area of mental health, and we have very inadequate response to it in terms of the degree to which it can adequately respond to the need. So here you'll see, this is from a report that I was involved in a couple of years ago. Of all the people in the community who have a mental health disorder, about 4 in 10 actually get access to services. And of those, only about 1.5 will receive minimally acceptable treatment in terms of its quality. And what I mean by quality is its adherence to evidence-based standards and so forth. And then even our evidence-based treatments don't work for everybody. So roughly about 66% of people will get benefit from those treatments. So when you do the horrible math here, you see that the current mental health system is not effective for about 90% of people in the community who are experiencing these kinds of problems. That's pretty bad, right? So we've got a problem to be fixed. And it involves various components. You've got prevention. So how do you prevent people from needing it in the first place? Access. How do you make sure people can access the services? Quality. How to improve the quality of the services people are receiving? And then effectiveness. How can we improve the actual effectiveness of the treatments that we have? Now, one of the things that the digital revolution has done is it suggests itself as a way to solve the access problem. Because what you can do is you can build an app or make something available online, you can automate it and take the human out of the loop, and so now you've got a system which is highly scalable. And so, brilliant. Everyone with a phone or with an internet connection has now got access to mental health care that's scalable. The problem is that we know, we've run this experiment in a number of ways, and we know that solving the access problem by itself doesn't actually make much difference. So this is just one example of many, many that have been run in the research literature. This is a paper from an Australian colleague of mine, Tony Jorm, and they looked at increases in access to mental health care across 4 high-income countries, US, Australia, Canada and the UK, and they found that there was distinct increases in access in all these countries, but their conclusion was, despite these changes, none of these countries showed any evidence of a reduction in the prevalence of disorders or symptoms over this period. If anything, there were changes in the opposite direction. So, and like I say, this is not an isolated finding. This is well recognised. So what's the problem? Well, the problem is that scaling access without improving quality doesn't achieve anything. And we really have to think about ways that we can use digital technology to improve quality. And one of the problems that we have is that because I've talked about this supply and demand imbalance, so, 4 in 10, 5 in 10 people actually get access to services. In children and adolescents, the rate is much, much higher, around about 80%. And this is an enormous burden on the US economic system and, of course, globally as well. So this is one of the fundamental features of the mental health system, is that there is an enormous supply and demand imbalance. And I was interested recently to look at what do economists have to say. I'm not an economist, so I was doing Economics 101. What do they have to say about what happens when there's a supply and demand imbalance? Well, here's some of the things that happen. There's a deterioration in quality of services as providers become overwhelmed and are stretched thin. There's increase in wait times and delays, price inflation, stress and burnout amongst employees, prioritisation of quantity versus quality, customer dissatisfaction, and potentially increases in unethical practices and misleading marketing. None of that was related to either mental health or health. That was all from general economic analyses. But if anyone in the mental health field will recognise all of that. clinicians are extremely stressed, and their major job these days is managing demand. The majority of practices, even in a high-income country like the United States, have either closed their books or are running very long waiting lists. It's very hard. It's certainly true in Eugene, Oregon. I'm sure it's true almost everywhere in the country. But you know, it's very hard to get services, especially for your kid. Really challenging. And so we see all of these things. So in fact, the supply and demand equation not only forces us to think about access as the solution, because that's the most obvious thing to do, but it actually also mitigates against us focusing on quality. So what we do is we start to increase access, but we don't have the economic incentive to focus on quality, because when you're not competing for customers, there's no motivation. Now, I do want to make a very important distinction here. I'm a clinical psychologist, and mental health professionals, like all health professionals, operate within very well trained in terms of professional ethics, and so I'm not suggesting that anybody out there is not doing their absolute best for each patient. They are, I can assure you. They're trying their heart out. But the system doesn't invest in things when there's not that economic motivation to do so. And if there's an economic motivation to increase access, like I can get money from more people, but there's no competition around quality, or the system doesn't actually pay people for quality, we'll talk about that in a second, then that's not where the investment gets made. Now, a famous, once again, doing my Economics 101 self-education, Thomas Malthus was one of the famous people in history to talk about supply and demand imbalances, because he was very worried about overpopulation in the late 1700s, and he was concerned that what would happen is the population would outgrow our capacity to provide food, and that this would be a catastrophe that would result in famine and poverty and so forth. Now, the catastrophe never occurred because he underestimated the capacity of technological improvement to actually improve the way we could produce food. And we now produce enough food to feed everybody. We don't distribute it very well. It's another question, but we do have enough food. So, sometimes I think in the mental health field we're a little bit like Thomas Malthus, looking and saying like, well, there's only so many practitioners and there's only so many hospitals and they can only see so many patients, so I guess we'll just live with it. So the question that has been really occupying me is whether we can address this. So there's some ineffective ways to deal with the supply and demand imbalance. One is to train more licensed health professionals. Now, we should train more licensed health professionals, let me be clear about that. I'm not against it at all. But the idea that that in and of itself will address the supply and demand imbalance is fanciful. It's way too big an imbalance. People have waiting lists, as I've said, also a very bad idea. Typically people get worse on waiting lists. There's actually some very good evidence that the longer that you wait for treatment, the worse things get for you. Or you can increase access to services that are not very effective. And we unfortunately do that a lot too. So what are some potentially more effective ways to deal with this supply and demand imbalance? Well, one is measurement-based care. The mental health field almost uniquely relies on self-report data, almost 100%. And there's nothing wrong with self-report data. It's very important to understand how people feel and what their perspective is. But only about 20% of clinicians actually apply even those standardised techniques. Mostly it's an unstructured interview. So you wouldn't say that most clinicians are engaging in measurement-based care. Now imagine if you went to your oncologist and all they did was say, how have you been feeling? Right? You wouldn't feel. The second thing is stratified care. We need to find a way to match levels of intensity of support to what people need at a given time, and to be able to do that flexibly. I'll talk more about that in a second. And then the final one is value-based care. So at the moment we have a reimbursement system that pays people for activity and not outcomes. And so once again, creates no incentive to optimise for outcomes, creates an incentive to optimise for activity. So I want to talk about a particular one of those. I could talk about this stuff for a very long time. So I'm going to just take one slice into this problem, which is the measurement one. And it's not that we don't have good interventions, but often it's how we deliver them, and we still deliver them in a very antiquated way with this sort of model of the office-based care, and the person comes and sits in the waiting room, and they talk to you, and they go home, and then they come back a week later, and so forth. And in fact, in mental health, there's almost this kind of belief that if the person bothers you during the week, that's actually bad patient behaviour. It means they have poor boundaries. Right? It's a bit of an old psychoanalytic concept, but it lives on. It's a zombie concept. But, we can't manage what we don't measure. That's axiomatic in so many areas of activity. And as I've already made this point, the physical healthcare uses objective measurement, behavioural healthcare uses self-report only. But surely, Nick, we can't measure behaviour. Got one of these? Got one of these? Measuring behaviour all the time. We're generating the largest data set on human behaviour that has ever existed. It's akin to the data set that was developed on language in the internet. There are accelerometers in so many different kinds of devices these days. So we actually are measuring behaviour, and it's not only practical, but it's scalable because consumer devices are already doing a lot of the heavy lifting for us. So I want to slice into one particular area of this to show you how this pans out in the area of youth suicide, which is an area I've been working on with some colleagues at University of Pittsburgh Medical Centre and Columbia University Medical Centre for a number of years now. So youth suicide has shocking statistics associated with it. Second leading cause of death amongst youth. 24% of young people have experienced suicidal ideation in the last 12 months. And about 10 to 17% of young people have had an attempt. And rates are increasing, especially amongst youth of colour and other minoritised groups. And you can see this is data that's getting a bit old now from the CDC, showing how suicide has increased to overtake homicide as one of the leading causes of death amongst young people. Now, how do you prevent suicide? There's a lot of different approaches, but probably the one that has the best track record is being able to interrupt the suicidal act at the time when it's occurring. For most people, sorry, not when it's occurring, that's misstated, but at that period of time when there's high risk. So for most people, this varies, but for many people who experience a serious suicidal crisis, the peak of that crisis when they're most likely to act will be a matter of a relatively short period of time, 15 minutes to a couple of hours. And so if you can actually find a way to interrupt that or to get them through that, then the vast majority of the time their mood will change and they'll feel that their options are different. So this is why one of our most powerful interventions is reducing access to means. If you don't have a gun in your house, that's very helpful. If you do have a gun in your house and you have the ammunition and the gun kept stored separately, that's also helpful. Anything that puts a little bit of friction between you and that behaviour. If you put pills into blister packs instead of bottles, that also reduces suicides because the mere requirement of just getting all the pills out of the blister pack reduces the likelihood that someone will follow through. Or you provide support or diversion at high risk moments. People who call a suicide support hotline are dramatically less likely to follow through to an attempt. So the point I'm trying to make here is that this is a when question. You want to be there at the right time. And the problem is that even the best clinicians are very bad at predicting when. No better than chance, mostly. We're not too bad at who. We can say this person may be at risk, but knowing when it might occur is actually something that we don't have good tools for. And this is where a concept such as the just-in-time adaptive intervention is very important. Some of you may have heard of this. It's been used in areas like substance use and eating behaviour and so forth. But the idea is that it's an intervention that provides just-in-time support by adapting to the dynamics of the individual's internal state or external context, highlight added, which is measured continuously, right? So we need a way of measuring that. And so that's one of the problems that we've been working on. And as I've already pointed out, your smartphone or your wrist wearable or your ring, whatever it may be, I'm a bit of a geek for these things, so I've got all of the three, is already measuring a lot of things that we actually know are related to mental health and wellbeing generally, and in some cases related to suicide risk amongst high-risk individuals. So for example, sleep. Sleep is a very powerful and reliable predictor when that becomes disrupted in a person who's at risk. We're also interested in language and so forth. So we've been building digital tools that allow this kind of collection of data continuously with the idea of being able to provide the just-in-time intervention. And there's more to say about that. So this is a fundamentally different kind of measurement than what we currently use. The current clinical measurement is a snapshot at a particular moment in time. The mobile sensing is always on and continuous, subjective versus objective. Effortful, so you need compliance from the person to provide the data versus something that's passive and automatic. Single input versus multiple sensors. And then the other thing about self-report techniques is they're always reporting on what did happen. They're always backwards looking. So this can be more proactive. And one thing that we know from literature, this is a study that was done a number of years ago looking at leading up to a suicide attempt and then asking people to track back to retrospectively recall their emotional state. And you can see that these distressing emotions rising just prior to the attempt. So emotional distress is a key target. And so this is one of the targets that we've been looking at. So this is an example where it's not based on mobile sensing, it's based on a single question. It takes about 3 seconds to answer, asking someone once a day, how was your mood yesterday? And this is a set of data from a group of young people who are highly at risk for suicide. And this has just come out in the Journal of the American Academy of Child and Adolescent Psychiatry, and what we found was that this single item rating of mood in this group, I'm not saying it would perform this way in the general community, but in this group does predict the onset of suicidal ideation. Another kind of more passive data that we've been very interested in, and we're interested in lots of them, but this is one example, is language. And the language patterns that people type into their phones. And so this is an example from one of my graduate students led this research. We followed a group of young people. These people were around about 13, 14 years old. And we looked at their the text that they were putting into their phone, and we found a couple of signals, some of which are well known in the literature, but they're repeated here. So the idea that your use of first-person pronouns increased with your level of distress. And this was true both cross-sectionally, that is between people, but also longitudinally within a person over time. You could track their changes in distress by tracking this use of first-person pronouns. Another word type was present-focused words. So the more you're talking about me and the more you're talking about now, the more likely you are to be experiencing psychological distress, and we saw a similar pattern there. All those rainbow-coloured lines there, this is one of the things that's very impressive to me, is that's the modelling within each individual in the study. So what you can see, almost everybody in the study is showing that slope, that characterises, the heavy line is the average across people. Another study we did was looking at a different group of teenagers. We looked at their language use and we predicted how likely they were to meet the criteria for major depressive disorder the next week. And this was over a 6-month follow-up period, and you can see once again first-person pronouns are a marker of increased likelihood that you'll experience the onset of that disorder over the next week. So look, there's a lot to... I just wanted to say this is not some of our research, but this is it was published in PNAS last year, and was based on analysis of psychotherapy transcripts. And what they found was that there was this concept that they called psychological distancing, which was indicative of higher well-being, the fact that you could stand back and distance from current experiences and so forth. And the linguistic features for that were low use of first-person pronouns and low use of present tense words. And they found that that not only improved over treatment, but it correlated with reduction in symptoms. It also tracked people's improvement both between participants and within participants across time. So, there's been a lot of cross-validation, and we've actually got another thing in the can which shows this again. It's one of those, people talk about the fact that we've got a replication crisis in psychology, and that's true. It's probably true in science generally, but this one, it's the little engine that could. It really just keeps coming up in different data sets, different samples, and so forth. So the point is, I don't want to give you the impression we've solved this problem. We haven't. But in terms of what we know works, which is to be able to provide someone with support at the time when they need it, we're starting to get some insight into some of the factors that may be predictive in that regard, and they can be collected in a scalable way. Now, knowing this group, I'm sure some of you will want to talk to me about ethics in a minute, and that's fine. Happy to do it. But, and this is another study where we looked at kids across time. I'm mindful of my time's going over, so I won't belabor this. But this is, if you want to look at the Journal of Psychopathology and Clinical Science, I have to look at that because it's a journal that changed its name recently. But then you can see that's impressed there. Same story. Okay. So what we're really aiming for here is a kind of a mental health system that achieves this measurement-based stratified care where someone can use a digital device to virtually access healthcare, but it's not just an app that's completely divorced from the mainstream healthcare system. It's something that critically, and this is critical, and this is what we haven't achieved so far very well, provides a low-friction entrance into the system, allows the person to scale up and down the level of support that they need, and doesn't cut out their opportunities to move that up or down as they require. So you can have different levels of support. You can have self-care using an app. You can have an automated system that supports you. You can have a coach, so there's a human in the loop, but it's very light touch, low intensity. You can step up to telehealth. You can step up to in-person, face-to-face consultations with a licensed professional, and some people will probably need to go to hospital occasionally. But the point is not that there are any... The point is the integration of these systems. And that's how I think you ultimately get to the point of being able to solve the access problem as well as the quality problem and the effectiveness problem, which is really the way, and that's I think the promise of digital technology. So, I wanted to acknowledge, as I said, some important collaborators on the few points of data that I presented and our funding support, and thank you for listening.
All right, thank you so much, Nick. Really appreciate that talk, and just again, the balance not only of thinking about the question of social media effect on well-being, but also flipping it and asking us bigger questions. So here we are at the Cyber Policy Center, and our vision for this center is to be at the forefront of whatever technological sort of controversy or crisis or issue of the day is. And so, closer to my mouth. Okay, I can do that. Thank you, Ben. Do I need to restate all that, or we're good? Okay. So Nick, the one thing I was sitting there thinking the whole time was, okay, I have the ring and the watch and the thing, and you have all the results suggesting like this could be useful. So what are the obstacles between achieving that vision that you had? So like we have the tech, everybody's wearing it. Mm-hmm. We have the mental health crisis, right? You have the data. Mm-hmm. What are the challenges? What does the Cyber Policy Center need to know that we should be working on or helping with?
Well, I think the essential policy features from my point of view is that the system has to be incentivised economically to improve patient outcomes. And if I could be king of the world for a minute and make a change relevant to the mental health system, that's what I would do. This is something I might say I was much less sensitive to before we started this damn startup, and and I'm an academic, right? And I'm like, I've got something new for you, and it's evidence-based, and it's good. There's good research behind it, and surely this will be exactly what you want, my friends. And then we go in, and what the practitioners typically say to us is, "That's great. It sounds wonderful for your ivory tower thing. I'm just trying to get by." Right, I'm managing really difficult cases. There's too many of them. I've got a waiting list as long as your arm. I don't need new data. I don't need you to tell me new ways of doing things. I need time. That's kind of what we're hearing from the clinical folks. And so how do you undo that not? That's the problem, because when you have... So I think the system is set up in a way where, as I said, it incentivises servicing. In some ways, it actually incentivises reductions in access, and of course the professions have a lot to answer for about that, of which I'm one. Because we like to have our little clubs and so forth that other people can't join easily. So I think that the whole system needs to be... I think we need to get away from the office-based delivery. I think we need to understand that probably most of healthcare, but mental health care in particular, is all about being there when the person needs you. So one metaphor that I use to illustrate this that works with some folks is, I say, imagine if you had a football coach who said to the team, "Listen, I'm not going to come to the game, and I'm not even going to look at tape. What I'm going to do is I'm going to have you come in and talk to me once a week about how you think you played. And then I'm going to tell you verbally how I think you could play better next week, and then I'll wait until next week and then we'll talk about it again." Now, it's absurd, right? And yet that's what we expect to happen. Behavioural health care is about behaviour change. And yet we try to deliver behaviour change in that kind of way. So I think we need to get away from that way of delivering things. And some of that's happening because of digital technology and the virtualisation of healthcare and at-home healthcare and so forth. So that's one point. But the second thing is, I think we need to make the system incentivised to optimise for patient outcomes rather than for activity. And that would be, so the move to value-based care. Now, last comment on that is, one of the problems, there has been moves to value-based care in other areas of healthcare. Mental and behavioural health has lagged behind because of the measurement issue. And so that's where I keep coming back to the measurement issue. As soon as you solve the measurement issue in a way where multiple people can agree this is a good outcome, then that facilitates value-based reimbursement systems.
Right. Yeah, I really just want to highlight 2 points there. One was, I've been looking at a number of different types of services, apps in particular in the mental health space, and they often are very divorced from the sort of mainstream healthcare thing. They're like, here's this app, you can do it to manage your anxiety, but it's not connected to anything else. think is important. And then I think this outcome-based part, it is kind of amazing that we're not doing anything, even though there are these measures. Okay, so it's Stanford, it's 2023 AI. Obviously, we have to ask that question. Massive amounts of resources being invested in AI in the mental health space here. We'll open it up to people ask questions because there's also ethical issues and questions around here. Do you see there's some opportunity to achieve the vision you laid out? Because, you know, we need more resources that are smart to be able to, you know, do that real-time thing, watch what's going on in behavior.
Yeah, so look, undoubtedly artificial intelligence and large language models in particular are going to have a huge impact in this area. We do know well some of the limitations of large language models is that they're not awfully good at precision, at least at the moment. They're better at generation of stuff. And that's a problem in healthcare because, you know, the thing is you have to look at each scenario and say, what are the costs of the errors? Right? And in some scenarios, the costs of hallucination on a large language model are virtually nil, right? So it's a good use case. And there's an upside. But in healthcare, there can be very costly errors. And so, you know, and of course there's a lot of people working on how do you constrain the models, you know, and so forth to make them more accurate and turn the temperature down. So it'll be part of it, but I do think that and it will be, and I'm sure that, you know, there will be increasingly skillful chatbots which will provide some kind of, or automated systems that will provide some kind of healthcare. But, and that will be, but I think this goes back to the point you made before, Jeff, which is I think that one of the problems that we repeatedly do in this area is we decide that we've got one slice of the levels of care, and we decide that's the solution. So, we made an app and it's available to everyone, so that's all we need. It doesn't need to be integrated with, you know, for safety and so forth. Or we've got a chatbot, you know, so the question is not, each one of those is valuable, and AI will have important contributions to make in making each of those solutions work better. I think it'll ultimately be used by clinicians, just as it's now being used by all your students to do their homework, and you know, and it's being used by people who write, you know, find it an incredibly good co-pilot tool, and I think that clinicians will find it a good way to, you know, access information, generate clinical notes, things like that. There'll be great applications along that kind of thing, but there will be. I think it's ultimately about enhancing the human capability, rather than trying to take the human out of the loop, which I think from the entire system. And so I think that's, but anyway, it's a lot to say about AI, obviously.
Here at Stanford, we have the human-centered AI
Yeah.
Institute. One of them is about like augmenting capabilities rather than replacing. Okay, great. Those are the key questions I wanted to get out, so let's open it up to the floor.
Can I ask
I see, do you have a question?
I do, and then I'll pass
great.
it along. So beyond the categories of protective and participatory rights that you suggested, what are the other rights of digital natives that should be codified into this type of research and work? As your title suggests, I want to focus on that, the ethics and the rights that should be included for youth and should really be at the forefront of all of this.
Mm-hmm.
Well, there's many, and as you're probably aware, if this is your area of interest, the United Nations Charter on the Rights of the Child has now got a digital sort of addendum to it, and there's also a British organisation that really articulates these well, called the Five Rights Foundation, if you may be aware of as well. So definitely, you know, there are organisations who are going to look at that. I was just picking two that are often where the tension point is when you're thinking about digital technology and mental health in youth. I certainly think that the right to privacy is obviously a preeminent one, but it's an interesting one because, so Jeff asked me before, what are some of the resistances we have in the system? So I've laid out the case for you as to what the potential value might be of continuous remote patient monitoring in mental health. When we talk to some people about that, they say, that's creepy. It's a word I hear a lot, right? Because they feel it's going to violate their privacy, and I get it. The irony, of course, is that their privacy is being violated in a much more profound and ongoing way, in ways that they're not particularly aware of, by major technology companies and so forth. And so, so the question is, people have a right to privacy, but also data is empowering. And the question is, who is empowered by the data? So the approach that we take is that the person has the right, if this thing I'm wearing is generating information that is relevant to my health, then I have, in some senses, a right to access that. And I also have a right to share it with people I want to share it with, and then unshare it when I want to, and I have the right to know exactly what those people are going to do with it. And so I think there are ways that you can, because the ultimate right to privacy is you lock all the data up and you don't let anyone use it, right? And so you've got to find a way of balancing the utility of the data and the potential empowerment that the data represents with the person's right to privacy and control and autonomy. And I do think that there are tractable ways to do that. So that would be another one I would focus on.
Thanks, Nick. Let's go Nate, then we'll go over here.
So I'm interested in the objective metrics that you were talking about that sort of should be where we're pushing. And so the ones I picked up on are sort of use of the pronouns that you mentioned. That's one. Maybe sleep, right, which is also measured. Can you maybe go through some others that feed into this? And then specifically because I was, when you had the slide on the study related to self-reported mood, and then it wasn't suicide, it was suicidal ideation, right? So which is also, I suppose, self-reported.
Correct.
Right, and so those things seem to cluster a little bit, right? And so
Yes.
self-report. So what I was persuaded by is that the revolution here is that you've got all this technology that can provide objective measures. Of course, the survey responses or whatever are also performing a role here, but I think the move that you're making here, which is important, is the objective stats. So, so one question is, you don't know, I mean, suicide is rare enough that I don't know whether in the suicidal ideation study there was enough actual suicides that occurred that you can see whether there was interaction. So I'd be interested in that, but then also just some of these other signals would be neat to figure out.
Yep. Thank you, great question. So let me go through some of the things. So one of the things is we've focused very much on the personal smartphone as the data collection device. You can augment that obviously with wearables, but the thing about the personal smartphone is it's highly scalable. So almost everybody owns one, at least in, well, I was going to say in high-income countries, but they've got enormous penetration in low and middle-income countries too. So much more than other kinds of devices. So that's the scalable solution. If you want to augment it with a fancy wearable, great, but that's the start. So what can you find out from the personal smartphone? You can track sleep, as I mentioned. You can track physical activity. You can track geographic mobility, and that can be very simple measures like, have you left home? Right, that would have been that was a very weird variable during the pandemic, obviously, but now we're returning to something where that's a little bit more meaningful, and that's got a strong track record as an index of wellness. But there's also to do with patterns of behaviour and rhythmicity and predictability of those patterns of behaviour. That's very helpful. And then there's also, as I said, it's a communication device, so you can collect language. We don't collect voice at the moment, although voice has got a very strong track record as an objective signal of mood. The reasons we don't collect it are technical rather than conceptual. So now when you look at all of those things, if you look at the research literature on lifestyles that put people more at risk or less at risk for mental health problems, what are the main pillars? Physical activity, social connection, nutrition, functional behaviour, being able to get out and do the things that you need to do in the world. And I'm not saying the smartphone collects all of those perfectly, but gives you a pretty good insight into a number of them. So so let me get to your other great question about objective outcomes. So yeah, we do, you're quite right, very accurate to pick up that particular result I showed you was for suicidal ideation. And ideation and action are not as related as you might think. You know, people can have ideation for a very long time and never take action. People can have not much ideation and have a flare-up and take action. So they're related, but they're not related as strongly as most people would imagine. And that's one of the reasons why it's hard to predict when it's going to happen, because you can have someone in your office with a lot of ideation, and you know, that whether that predicts what they'll do this week is not particularly accurate. So we do have other analyses where we look at you're quite right, it's a low frequency event, so what we tend to do is put it together a category of things like hospitalisation, visits to the emergency room, you know, calling a crisis line and making an attempt, and put them together, but they're all behavioural. And we've got some very interesting findings predicting those. I didn't review them today because they haven't been through peer review yet, and it's a shorter talk. But we are very focused on that set of outcomes as well, because that's obviously where that's what we all care about at the end of the day is you know, preventing loss of life, unnecessary loss of life.
Just a quick follow-up.
Mhm.
Did you find any, and I'm sorry for repeating, any correlation with use digital devices, social media, and the kind of things that you started the presentation with, and any of the behavioral outcomes? I mean, maybe, of course, the causality may go both ways, but
Yeah. The studies I was telling you about, we haven't looked at that yet. But I'll just leave it at that. We haven't looked at it yet.
Yeah. Thanks. Over to your left, Nick.
Hi, my name is Alma. I am really fascinated by this presentation, and it's very, very meaningful. It's really beautiful to see like meaningful applications of technology. I think it's lacking in our world sometimes. I grew up in Palo Alto, and I went to gun high school, and we have had a serious suicide problem for many decades.
Yes.
And so while I think it's really powerful the way that you're using this tool to potentially offer life-saving interventions, I guess I'm curious, just based on my own personal experience, what the plan is to create trust with users. You've spoken a lot about, you know, the communication with clinicians and how to offer support to them, which
Yes.
makes a lot of sense,
Yes.
and about the economic incentives.
Yes.
But when I think about me at 14, and I was going through a lot of these mental health crises, if I was getting a app reminder being like, hey, you sound suicidal today, I would have been like, what the fuck? I'm throwing my phone into the garbage. Like, I'm not. So I guess my question is twofold. It's who are you testing with?
Mm-hmm.
Who are you getting consent from? Is it the 13-year-olds themselves? Is it their parents that want to have a closer grip on their children's mental landscape? And how are you going to design the interventions so that the children themselves feel that they can trust this technology rather than it's adversarial to them?
Mm-hmm. Yeah. Thank you for a great question. Okay, let me back up with a higher level comment. Our experience is that people are happy to share data with a system like this if two criteria are met. One is whether they trust you, and the second one is whether they get value from doing so. Right? And if you can meet those two criteria, then people will often feel comfortable sharing data. In terms of, you know, the kind of feedback that people get or alerts and things like that, the critical thing there is to actually allow the individual to personalise that. And so, for example, you know, there's a whole literature on what's called suicide safety planning. So after someone has made an attempt, in order to prevent that occurring again, one of the things that you do is you develop a set of resources that are individual to that person and meaningful to them individually, about reasons for living, for example, about perspectives that they personally want to be reminded of at these times of distress and despair, and that they get to control both what that content is, so it's not coming from another person, it's actually something you put in the system yourself, right? It might be a picture of a loved one or a pet, or it might be something you're looking forward to, or, you know, so they're personally meaningful messages that are sent, not some kind of big brother-ish, like, you're about to do this. And then secondly, you get to control who else knows. So you get to say, like, well, I'd like this person to be aware that I'm not doing well, and you get to change that when you want to. So I think there are ways, and that's where, if you look at the literature on nudging and behavioural economics and so forth, there's, you know, that's one of the messages that come through. When it's personalised, when it's specific, you know, that's when it's most powerful, and when it comes at the right time. So I think that there are a couple of items that I would consider, and thankfully they're things that are already in they're already in the knowledge base to an extent. You know, another intervention that's often used as what's called a post-vention intervention for suicide is sending what are called caring contacts. So people get a contact, a follow-up. Let's say they went to the emergency room, they were experiencing a suicidal crisis. Then rather than it being like, okay, you're over your crisis, see you later, you know, we'll see you next time, it's more like, we're going to have a follow-up here of messages, caring contacts from someone in the healthcare system, or with veterans, for example. You know, there's some really interesting research there showing that if it's another veteran who's sending you the caring contact, then it's especially effective. So the general point is these things do need to be personalised, and they do need to be chosen by the individual. And I think when you do that, that feeling of what did you say? What the hell, or something? Yeah. Yeah. Cleaned it up for you a little bit, but yeah, hopefully that'll be less. And of course, you know, the idea of a nudge is that you can ignore it. I mean, you have full autonomy not to follow it. It's just something to remind you. It's your past self looking after your future self.
Just a super quick follow-up on that. Is this something that you are planning to institute for, like, individuals who have already attempted or have been having ideation, or is it going to be something that all individuals that are receiving a certain type of psychotherapy will be enrolled in to catch it, like, the first time or something?
That is a fantastic question. Thank you for asking it. So I think the answer is both, but it looks different in each case. So there's definitely this sort of what's called post-vention idea, which is sort of prevention post the attempt or the crisis. And then there's also the ability to apply some of these methodologies in a more population-based way to kind of help everyone to improve their well-being by looking at those fundamental pillars of well-being, as I mentioned before: healthy sleep, physical activity, social connection, you know, etc., and good nutrition, and all the other things that we know actually do predict, you know, quite strongly and reliably people's vulnerability to mental health concerns. So, yeah.
Great. Ben, do we have time for one more? Or? Okay. So this is coming from online. It's our friend Ravi Iyer. And he's got a great question, I think, that ties together a couple of pieces. So he's saying, you know, we might have difficulty drawing causality in social media generally and some outcomes, but he's wondering if there's some specific things we could think about. And I know you're doing work around sleep and phone use. So his question is, like, is optimizing for engagement, could that lead to more difficulty with sleep or with more disturbing content? Would it make sense to take approach like you're doing here in the healthcare space and thinking of more specifically of this particular design choice is related to this particular outcome? Yes. Yeah. I think he's just sort of like getting your sense of whether that would also work there.
Yeah, I think that's the much more sophisticated and right way to go. So let me be clear. I'm not saying that digital device use cannot have a role in mental health difficulties generally, or for a particular individual. But the category is way too broad. We need to understand, first of all, it's a little bit like, I don't know, reading, or, you know, what are you reading? You know, like it captures such a heterogeneity. And when we ask questions about things like screen time, we lose that nuance, which I think is absolutely critical. So, and I think the second thing is we need to know there may be mediators or mechanisms that actually explain this. Now, sleep is actually one quite plausible one. And there's literature there that if you use your device in a way that displaces healthy sleep, so we'll see what's going on there. And the other thing I'll say is that, just to give them a little bit of a shout out, we're doing a project with Google, which we just finished collecting, about 10,000 people all around the country, looking at their device use for a month objectively, collecting data on things like sleep, physical activity and so forth. About 80% of them are wearing Fitbits. And that data set is we're just starting to scratch the surface of that. And Google was willing to do that, and I think that speaks well of them in that decision, at least, to look seriously at their products and what the effect is on digital well-being and on well-being, and what the digital effects are. Yep.
Great. Well, thanks, Nick. And before we thank Nick, I'll just do two things. One, I do struggle now when people ask me about social media and well-being. Is like there is no social media anymore, right? Like the news feed is not like TikTok, which is not like Snapchat, which okay. And so that's been frustrating. And then this notion of well-being, like how many different aspects are there? So it's been challenging for sure. I also wanted to give a shout out for the talk that's next week. Do we have that slide? Look at that. So well planned. We have 3 of the authors from the folks looking at the Facebook papers. So Neil Malhotra from the Business School, Jen Pan from Communication, and Pablo Rivera, who's with Meta now. We're hoping will come and visit us for some time. And it'll be more of a sit down, so it'll be moderated, and we'll be able to ask some questions that you may have about that whole series of papers. So really excited for next week. Please join me in thanking Nick for a really amazing talk and new perspective.
Thank you.